We'd like to welcome everyone to the OR Today webinar series. We are excited to have over 300 pre-registered attendees for today's webinar. We'd like to remind everyone that the second annual OR Today Live Surgical Conference will be held August 28th through the 30th at the Hilton Oak Brook Hills Resort in Chicago, Illinois. All of our educational sessions presented at OR Today Live meet the CE requirements for the CSSM certification exam. Attendees can also participate in a pre-conference mini MBA workshop hosted by CCI titled Fundamentals of OR Management. You can learn more about this one-of-a-kind conference by visiting ortodaylive.com. Speaking of Chicago, we'd like to give away an OR Today Live tote bag to the first attendee that can tell me what 3,300-foot-long Chicago shoreline landmark is celebrating its 100th birthday this year. You can use the question feature on your webinar dashboard to answer right now. While you're answering, I want to remind you that today's webinar is eligible for one continuing education hour. To obtain your certificate, you must complete the post-webinar survey, which will appear immediately on your computer screen at the end of today's call. If you do not receive the survey, please email us at webinar@mdpublishing.com. Okay, looks like we have a winner. And it's going to be Mr. Brian Desso. Mr. Brian Desso correctly said the Navy Pier is celebrating its 10th anniversary. Congratulations, Brian. All right. OR Today would like to thank our sponsor, Fluke Biomedical. Fluke Biomedical is the premier global provider of test and measurement equipment and services to the healthcare industry. They serve biomedical engineers, quality assurance technicians, medical physicists, oncologists, radiation safety professionals, and physicians. Visit them at www.flukebiomedical.com for more information. We'd like to welcome the presenter today, Chintan Shah. Chintan manages America's marketing and sales for the Realtime Staff Dose business. He has been with Unfor's RaySafe, a Fluke Biomedical brand, since 2011. In that time, he has gained expertise in radiation safety practices for high-dose clinical medical professionals. Chintan, you can begin whenever you are ready.
All right, thank you very much. Appreciate the introduction. Looking forward to spending a little bit of time here today with everybody and telling you a little bit about radiation safety and seeing how we can help improve your practices on a day-to-day basis. So the title of our webinar here is the ABCs of Radiation Safety, and that is avoidance, behavior, and control, together being able to achieve dose reduction. So what we hope to cover here today is to talk a little bit about some of the basics of radiation safety, understand what your risks are in terms of radiation exposure, and then talk a little bit about how to manage those risks, what kind of guidelines are in place and recommendations that are in the marketplace today, and then especially focus in on the solutions to reduce your exposure, what kind of protective equipment you have at your disposal, hopefully much of which you use today, and perhaps give you some ideas of things that you may not be aware of. And then share with you a little bit of some of the new technologies that are out there today in terms of robotic systems as well as radiation monitoring systems and equipment. So as John mentioned, I've been with RaySafe, which is a Fluke Biomedical company, for the last 5 years. Prior to that, I worked for IBM in New York. Originally, I'm from Wisconsin, which I'm very proud of. I'm a proud Packer fan. And so one thing I will just personally add is my mom, who actually, her career has been spent in as an X-ray technologist as well as in mammography as a tech. So I had a little bit of, pardon the pun, exposure since I was little to what that all entails and what's included in that. So as fortune would have it, I ended up in this business, in this industry, and so learned a little from when I was young. So our company, RaySafe, our motto is actually like a canary in a coal mine. And what that references is back in the old days, in the coal mines, there would be a person responsible for safety, and they would carry a little cage with a canary in it, and they would go down to the mines, and that canary would be chirping away, singing its song. And if that canary stopped singing, then they would know that there were toxic gases in the air, and that would be their signal to vacate the coal mine and to go back, and they'd have to do a number of things to kind of clear it out and make sure it's safe again. Well, in the same way, RaySafe is that early indicator for you in the lab or in the workplace where you are. And so all of our products really emphasize that early indication and that safety and protection. And so that's really where our Canary comes from. So let me share with you a couple of items here in terms of what we hope to achieve today. So as you know, intervention and interventional therapies, they're well documented. They are great tools for diagnostic medicine, and they have a lot of benefits for patients. However, as we know, radiation as a tool has its benefits, but also has its detrimental side effects. And there are a number of health risks, both for physicians and the extended staff members, technologists and nurses, of which hopefully many of you are in the audience today. And there's a number of issues, both from the radiation itself as well as orthopedic side, that we'll touch on today. So when we finish here, and part of you receiving the credit that you will be at the end of the course, is to understand the basics of radiation exposure and know really what those associated risks are, because there are several. And then most importantly here, your takeaway is to understand how you can reduce your exposure to that radiation. What can you do on a day-to-day basis, week to week, month to month, ultimately over throughout your career, to lower your exposure and to manage your radiation exposure. And then, since you're on the call today and since you're joining, we'd love for you to be able to educate others and educate your peers about how they can improve their practices as well. One additional thing I would touch on is that hopefully throughout your careers, as you went through your various training programs and educational programs, you've had an opportunity to learn about radiation safety throughout the curriculum. Sometimes it's a core piece, other times it's an additional piece that you might have added on. But we believe that, and we know that that's really a part of the curriculum in medicine. And so whether you're a physician, a nurse, or a technologist, or some other role, it's really been something that you've been taught. What we're hoping to do today is kind of refresh some of those courses you may have taken, and perhaps give you a few additional things that you can take away. The other important point is that on a day-to-day basis, you have quite a few priorities that you have a responsibility to attend to. And what we all know is that radiation and radiation safety can kind of fall on that list of priorities and those responsibilities. And so what we would like to do is try to help you keep that top of mind so that when you go back to your day job, your day-to-day responsibilities, you always have that in the top of your mind about how can I focus and emphasize radiation safety. So let's talk a little bit about some of the exposure and the basics of it. So what is medical radiation and why is it important? Hopefully this is nothing new, and again, it's more of a refresher, but ionizing radiation is what we're talking about when we talk about X-ray and in the medical environment, and it's used on patients and on the body in order to both diagnose and treat medical conditions. And so there's a number of different modalities throughout which this can be used. Anything from CT to any fluoroscopy, X-ray, mammography. And the long-term effects of these can lead to all kinds of different negative side effects and potentially cancer, cataracts, and other things which we'll talk about. And the key is if it's not properly or appropriately controlled or monitored. And that's really what we'll spend some time talking about. So, the amount of radiation resulting from fluoroscopy is highly variable. Patient dose from fluoroscopy exams are dependent upon the amount of radiation that's used to generate each image. And those images, whether they be radiographic or fluoroscopic, are really what we're talking about. Typically, a medical physicist working with the hospital will work closely to ensure that the equipment putting out the amount of dose that it should be, and that the images can be optimized as well. The other key thing to remember here is that patient dose is dependent on the number of fluoroscopic images that are taken. And so whether it's the number that are taken or the longevity of that exposure, those are the types of variables that we're trying to discuss here. Okay, so when we're talking about an X-ray source, typically there is an X-ray tube. In this case, it's labeled C. And the X-ray actually comes out of the tube. And I'll show you a picture in a few minutes here about how X-ray is scattered off. But it starts at the tube, goes up through the table, through the patient, and then to what's pointed out as just above the letter A there, which is the detector. And so X-ray, which is also known as the image intensifier. So X-ray will come out from the tube, go up through the table, through the patient, and then into the computer, and then it scatters off. And these are the various sources of X-ray for you working in a lab. All right, so before I get to this, I think we have a poll question, and hopefully Jamie can help me out with that.
We do, Chintan. I'm going to go ahead and launch the poll for the attendees. You should now be able to see the question, are you aware of the term Olara, A-L-A-R-A? Your options are yes or no. Please do select one of these answers. While you're doing so, I want to remind all of the attendees, we're going to wrap up today with a Q&A. Chintan is excited to address any of the questions that you submit today. You can do so throughout the presentation by using the question feature or even the chat feature on the bottom of your dashboard. Again, all questions will be saved to the end of the presentation. We'll get through as many as we can, but if we don't address your question, Chintan will follow up with you offline. It looks like over 80% of the audience has voted. Chintan, I'm going to go ahead and share these with everyone. And 55% of the audience was aware of the term Olara, 45% was not. Chintan, you can pick up your presentation whenever you're ready.
Okay, very good. So it sounds like about half of you know what the term means and the other half does not, and that's absolutely okay. So the term Olara stands for as low as reasonably achievable. And that's really the core driving principle behind radiation safety. It really means that you try to achieve the lowest dose possible, but you do so when it's possible. So we're not going to focus on radiation safety at the detriment of patient care, but we're going to do all the steps that we can to try to reduce the amount of radiation as we can. So there's really three primary principles around achieving Olara, and those are time, distance, and shielding. So time means, very simply, the amount of time radiation is used. Less is, of course, better in terms of radiation. Distance, there's a term called the inverse square law that tells us that the more distance we create from the imaging source, the less the impact of that radiation will be to our cells. And so that's another important principle that some of you may have heard. And then lastly is shielding. And shielding reflects using different types of devices in the lab to of course, help us absorb that radiation or deflect it from our cells. So those are really the three principles that medical physicists and radiation safety officers and others are really talking about when they're trying to achieve Olara. So then, if those are kind of the core principles, there are steps that we can take around radiation safety when it comes to the actual imaging system. So the first one is frame rate. And that means the number of images that are taken over the course of an exposure. So there are different settings within the system, and they can be as low as 0.5 or 1 frame per second, or they can be as high as actually 30 and even higher than that in some specialized systems. What's important to know is that the higher the frame rate, the more radiation is used. And so there are times when you do need very high frame rates because you might be putting a guide wire or other device in the body and you need to see that image refresh regularly. However, there are other times, and very much oftentimes, when lower frame rates can be used and still give you an extremely clear picture that is more than acceptable for whatever the diagnostic or interventional procedure might be. Another term that's important is collimation, and that's really talking about the beam that's used and how wide of a beam is actually being shot at toward the patient. Wider, the more open beam, the more scatter, the more radiation is going to be created, and the more narrow the beam, the less will be created. So these are settings, these are adjustments that can be made live in real time during a procedure, and those are things that can actually help dramatically reduce exposure. So let's talk a little bit about the risks of radiation exposure. And so a couple of things. There's two kinds of risks that we're talking about. The first is called deterministic. And that type of injury or that kind of problem reflects injury to multiple cells, and there's a threshold of dose, which is going to affect those. And some of these injuries are skin arrhythmia, epilation, which typically means loss of hair, and then ulceration on the skin itself. And so oftentimes these can happen and do happen during fluoroscopy, and they can be both complex and complicated during various types of intervention or other kinds of operations that are done. And typically adults will have these problems, but of course children are susceptible as well. The second type is stochastic effects, and those are really related to single cell injuries rather than multiple cell. And this is directly proportional to the amount of dose that's used. And so the longer you are exposed to radiation over a 5, 10, 25, 30-year career, the higher the chances of stochastic effects of radiation. So what you see here is that the amount of exposure for patients and staff has increased quite a bit, especially since 1980. You see that number go up. We often talk about interventional cardiologists here, but much of what you'll see throughout the rest of the presentation really reflects multiple modalities, whether it's interventional radiology or vascular surgery or other areas as well. And so the key here is that higher doses of radiation over long periods of time have negative side effects. So another important point here is when you are in a procedure, location matters, right? The axiom is location, location, location. So if you take a look at the little image on the bottom, you can see that there's kind of 3 or 4 different positions that have been highlighted. Position number 1 is typically your operator, your physician, will be standing at the table. And they're, of course, closest to the imaging source and usually performing the procedure with catheters and stents and other devices. What is interesting to note, though, here is that while 2, who might be, spot number 2, who might be a fellow or a tech, and then 3, they're kind of shielded there by that physician. Their doses are very low. In fact, number 3 is extremely low. But what's interesting is that number 4, spot number 4, who might be a nurse or another tech, standing on the other side of the table, is actually getting significantly higher dose than even the physician. In fact, it's more than 3 times. So the location that you're standing in is very, very important. And if there are times where you can move or adjust your position, that's really going to be what helps you keep and manage your exposure over time. So a couple of points here in terms of how radiation affects you and where potentially it can impact you. So I talked earlier, there's kind of 2 areas. One is how radiation impacts you, and the second is orthopedic strain and standing for long periods of time, wearing heavy shielding and what that can do to you. So we first see that cataracts are something that often cause health concerns among staff that are in the lab. There are a number of studies that have emerged here over the last 5 years that highlight an increased prevalence of left side brain tumor among clinicians. And these are oftentimes interventional radiologists, interventional cardiologists, and even now some vascular surgeons that are talking about that have personally reported cases of left side brain tumor. We also know that there's an increase of leukemia and lymphoma, and any female who is pregnant that does work in these labs also has to be very careful of the effects to that pregnancy. In terms of the orthopedic strain, we know that eye strain from focusing on images or on a patient for long periods of time, along with probably one of the 2 of the most prevalent ones are back pain and joint problems. And those typically come from the fact that you're wearing a heavy lead apron for extended periods of time in the lab. And so whether you're hunching over, whether you're having to bend down, that's putting a lot of strain on your body. And so these are things that we know cause side effects. So I touched a little bit on both cancer and cataracts. We know, for example, that cardiologists can have up to a 50% higher chance of getting cataracts throughout their career. And we know this not only from clinical studies, but at many of the conferences, there will be free cataract exams, and a lot of times those are things that are reported during the conferences that physicians learn about. Additionally, with cancer, I talked about the left side brain tumor studies that have emerged, and it is no coincidence that these are oftentimes reported as left side. And the result of that is that physicians are typically standing with the X-ray source on their left, which means it's really the left side of their brain that's being affected by the radiation. Talked a little bit about the orthopedic strain, and so hip problems, ankle problems, spinal issues are really the largest cause of missed time in the labs. And so what you can do, and there's a number of different suggestions that are out there that are part of the workplace, but taking off that lead vest, doing different stretching exercises and things, and really trying to minimize the amount of time that you need to have that lead on as a key point. So let's talk a little bit about what guidelines there are to manage radiation. So I showed you earlier where the X-ray comes from. Now let's talk a little bit about scatter radiation. So whenever X-ray is used and it comes out of that X-ray tube, about 65 to 70% of the X-ray that comes out goes into and is absorbed by the patient. So 60 to 70%, 65 to 70% of that goes into the patient. Less than 1% of that X-ray actually goes back into the image receptor or the image intensifier to actually make the image on the screen. And it's really 30 to 35% of that X-ray that's scattered off to the staff. So for those of you folks listening today, that's really what you have to be concerned about, is 30 to 35% that's scattering off and could potentially affect you. So I come back to the Olara principle, and it stands for as low as reasonably achievable. And the principles of Olara are what we touched on, which is time, distance, and shielding. So we really try to minimize the amount of time in a lab and in front of radiation. We try to leave the room when you can, and we'll talk a little bit about what that could potentially look like. And really reduce the amount of exposure time that you're near the source. And being very vigilant about where you're standing, as we touched on location. I mentioned the inverse square law, and the distance that you can create between yourself and the imaging source has a tremendous effect on your personal exposure. And then we touched a little bit on shielding and using best shielding practices. And we'll talk about some of the equipment that's out there today, but using lead aprons, thyroid collars, especially lead glasses, and the movable shielding that exists in the room. The other key point are dosimeters, and really wearing the dosimeter that you've given. Every radiation worker, every worker who's in a radiation environment in the U.S. is required to wear a legal dosimeter. And so it's very important that you do that. It really helps keep track of what kind of exposures you have and helps your radiation safety team, whether it be a radiation safety officer or the medical physicist, better manage dose, not only for individuals, but for the whole staff in general. All right, so let's talk a little bit about some of the solutions for radiation exposure and what some of the best practices are and what some of the equipment is. So some of the procedural, this kind of procedural and equipment best practices. Procedurally, if you don't need to be in the room, you really shouldn't be in there. I'll tell you how many times I've seen folks that are stepping into a room or might be in a doorway. We're not part of the procedure, but happen to be just standing in the doorway, chatting, taking a coffee break, what have you. And that's really not what you want to be doing, because X-ray travels, it moves in unpredictable patterns, and you might be really exposing yourself while you're in the doorway there. It's also important to keep your hands out of the beam. And I'll share a short little story here, but I was in a procedure room, and there was a nurse, we'll call her Susie. She was very caring, was really attentive to what the patient was going through, and recognized that it was very uncomfortable for the patient. And observing a number of procedures, I noticed that she would regularly step up to the patient, and in fact she was putting her hands on the patient, checking catheters, ensuring the patient was okay. Well, what she didn't realize she was doing was putting her hands directly in the beam. And obviously doing that puts her and increases her risk to all kinds of different things that we just talked about. And so a big concern is how close you are to the beam and whether or not you're putting your hands in the beam or other parts of your body, especially for physicians leaning into the beam. And I've talked about a couple of these things in terms of movable shields and optimizing the position. I think the other key is to always take a step back if possible. When and if possible, take that step back. And we'll talk about some things that are out there today that can help with that. Another important point, and I know I showed you this on the picture, but the important thing to note is that the X-ray tube is underneath the table. There's often this misconception that the X-ray tube is at the top and the detector's on the bottom. It's actually the other way around. The detector is at the top, and the X-ray tube itself is on the bottom. And then for those operators who are actually controlling the X-ray, hitting the foot pedal, it's important to use to keep the image intensifier as close to the patient as possible. And the lower that is, the less scatter that there's going to be created. And then using collimation as much as you can to help reduce the amount of X-ray that's scattered off. So there's a number of technologies that I mentioned that we will be talking about here. So there is not only radiation monitoring equipment as the dosimeters, as I mentioned earlier, but there's also personal protective equipment that can be utilized. And these are different systems, which I'll get into. And then there are some newer robotic systems that have very specific uses, and I'll touch a little bit on what those are and in what particular uses they can have a lot of value. So let's start with the personal protective equipment. The goal of personal protective equipment is to reduce exposure and absorb the scatter radiation that are being sent out throughout the room. And these are things that you personally can do, can use, can wear, that are going to be able to help you. So, and I'll ask this most as kind of as a rhetorical question, but how many of you actually wear the radiation safety lead glasses that are available to you? And in my experience, it's not nearly as high as we would want, whether it be physicians, nurses, or technologists. And even I would say, especially among technologists and nurses, we often observe fewer people wearing them than probably should. The lead aprons and the thyroid collars are, of course, a necessity and are pretty much everywhere. I really have not seen anyone walk into a lab without wearing lead. But wearing that thyroid collar is extremely important because of the risk of thyroid cancer when exposed to a lot of radiation. There's other devices that are out there. Some of these might be new to you, but there's some various head shielding, which you see there kind of looks like a visor. There are attenuation gloves, and these are really gloves that can help reduce exposure to your hands. They have a lead lining, and so these are different things. Typically, the operator would use those, especially those types of physicians who might be very close to the X-ray source would be the one to utilize those. And some of the newer things that have come out, especially this lightweight lead cap, is something that rather than your traditional surgical cap, these have a thin lead lining along the top, so they keep your head and the side of it and the back of your head protected. Of course, there's always some positives and some negatives. Some people do believe they're a little bit heavy, but they do have some positive effects and can potentially protect your extremities. Next are some of the other protective equipment that's out there, and these things should look familiar. There's stationary or mobile shielding. It can be everything from rolling shielding that get moved in on a case-by-case basis to movable shields that are oftentimes hung on the ceiling that can be adjusted by the physician or anybody in the room, and that can be better positioned to block that scatter radiation. There's a device called RadPad, which are disposable radiation pads that can be placed on the patient or around the patient, and they actually absorb scatter radiation, and those can be used. I've seen those used by different facilities. And then there's a newer system called the Trinity Protective System. It's something like a wall that can be placed in, and that can help reduce the amount of exposure from the source. So let's talk a little bit about robotic systems. There are a handful of robotic-assisted systems. Some of them focus on coronary uses, like angioplasty or PCI. Others focus on peripheral, and so there's a company called CorePath, or a product called CorePath from Corindus. There is the Magellan robotic system for peripheral cases. And then for electrophysiology, or EP, there are different types of robots that can be used that can automatically place catheters and stents into the patient. So of course these have benefits, and the advantages are that not only can the individual who's controlling the catheter be further away from the radiation source, but it can help reduce the amount of time that radiation is actually needed for the case. So for example, the CorePath system allows the physician to actually sit in a cockpit away from the table, and they can control the catheter from a little dashboard with a little joystick. and they can be very precise with the placement of both the catheter and potentially any balloon or stent devices that they're using. Similarly, the Hansen system also has a cockpit that they can use, which allows the physician a remote workstation to be away from the patient. The Epic system is a little bit different, meant mostly for electrophysiology, and it actually utilizes remote magnetic catheter controls and allows more efficiency for this particular robotic device to manipulate the catheter. And then it's a sophisticated data integration system that allows the transmission of these catheters in a better way. And then there's also this Sensei robot, which is a similar robotic catheter system. It has its own unique uses, particularly for arrhythmias. So just a flavor and example of a few different robotic systems that are out there today. So the next thing we want to talk about is monitoring equipment and systems for actually measuring and monitoring radiation. So there's really a goal of monitoring radiation and then being able to determine the effects of it over periods of time. The most common and the traditional and required monitoring system is really the legal dose badge, and hopefully all of you are familiar with the badge. Often is either a hexagon or might be a little rectangle that you wear. It can be replaced on a monthly or quarterly basis, get sent out to a lab, and you get a report. And that's really what radiation safety in your department will use to determine what your doses are for the month. And that is a legal reporting mechanism. There's also a new system around real-time radiation monitoring called the RaySafe i2. So we'll talk a little bit about that here now. So this is a typical example of the RaySafe i2, which is a real-time dissymmetry system in action in a lab. So it consists of a few different components, and I'll show you what those are. There, as you see in the middle picture there's a little real-time display that's located right above the patient image. And every staff member wears a real-time dosimeter that allows it to capture the amount of radiation that they're exposed to, and it shows it to you on a screen. And then on the back end, there's some software that allows the staff to actually manage their exposure and see how they're doing compared to their peers. Really the key here is, because we've talked about this here today, radiation, you can't see it, smell it, taste it, or touch it. This system, which is what our company has developed, really helps you visualize radiation in real time. So you can think of it like you do of a stoplight when you're driving a car. And whenever you're in a procedure room, if you can see your name up on the screen, and you'll see either red, yellow, or red, that indicates how much radiation you're being exposed to. So it's very simple. Green is good, and red is bad. I'll say it again. Pretty straightforward here, but green is good, and red is bad. So if you see that your name is lighting up in the red, there are things that you can do, just as we've talked about, distance, time, and shielding. Take a step back, move over, use the shielding, and that's going to actually help you reduce your exposure in real time. So that's really the benefit of the RaySafe i2 system, which is that you'll be able to visualize the X-ray in real time, and it'll help you to kind of take control back or empower yourself to manage your own exposure. And so what we've seen is that physicians and staff are able to really lower their dose. And some of our clinical studies have actually been able to replicate a success of 40% less dose. And that's a pretty compelling amount if you think of the amount of time you might spend in a procedure room throughout your career, whether it be 5, 10, 15, or like I said before, 25 or 30 years. So as we look to kind of wrap up here, we've talked about a number of different things related to the risks of exposure. And we know and you know what, before I actually jump to that, I'm going to go to Jamie here real quick. I know we have one more poll that we wanted to ask, so I won't jump too far.
I do, Chintan. I'm going to go ahead and launch the poll. The attendees should now be able to see the question. Have you heard of real-time dissymmetry prior to today's webinar? Your answers are yes or no. Please do select one of the options. I'm going to take a moment just to remind everyone, the workbook for today's presentation does include a case study, an opportunity to download a case study on the information that has been presented today. If you didn't receive that in the email, you can download the PDF on your webinar dashboard by going to the handout section. But if you have any questions or any technical issues with that, just email us at webinar@mdpublishing.com. I'll be happy to send that workbook over for you. Chintan, it looks like 90% of the audience has answered, so I'm going to go ahead and share the results. 39% answered yes, they had heard of this before, and 61% said no. You should be able to pick up with your presentation whenever you're ready.
All right, thank you very much. All right, so it definitely sounds like the awareness around the real-time system is new for many of you, and I think that's a great learning point for us and something that, that hopefully you folks can take back for your teams as well. So as we've talked about today, the risks of radiation are very real. You know, irrespective of which modality you personally are in, whether you're in an OR, whether you're in interventional radiology or cardiology or anything else, it's important to know that there are real risks for radiation that they can cause, from cancer to cataracts to non-radiation problems that are related to orthopedics. And so taking the right action, taking the right steps to help minimize those impacts is important. And I mentioned this earlier, and I think we have 55% that were aware of the term Olara, but hopefully now we're at 100%. And all of you can walk away knowing that Olara, or as low as reasonably achievable, is really the core principle that guides low radiation. And so anything that you can do in terms of better wearing or utilizing radiation monitoring equipment and personal protective equipment will help throughout your day, throughout your career. And so that's what we'd really like you to take away from this particular talk today. And so we call it as easy as ABC. Avoidance plus behavior plus control is what will help yield dose reduction. And what you want to do is really reduce your exposure today so that you can prevent consequences later. So for everyone on the call, thank you very much. Really appreciate your time, and would absolutely be happy to take any questions that you might have, or on anything that I touched on, or anything maybe that I haven't talked about.
Thank you, Chintan. Fantastic presentation. We have a lot of questions, great participation from the audience, so we're going to go ahead and get started. For the facilities that have implemented and installed the RaySafe i2, how successful has it been in reducing dose, and did it change staff behavior or change how they operate in the OR?
Thank you. It's a great question. So we actually have seen that the RaySafe i2 system has been incredibly powerful in helping to change behavior. And not only change behavior, but sustain that change. And so I'll give a couple of examples. At the University of Rochester in Rochester, New York, we work with that hospital. They had a number of radiation safety challenges, and they implemented the RaySafe i2 and real-time system. And what they saw is almost immediately when they put the system in, they saw that people's eyes were completely open to the fact that, hey, you know, I usually stand in this spot right here, and I always thought it was safe. And in the first case that I was in, I saw right next to my name that I was lighting up in the red. And I realized that, hey, maybe this is not the safest spot. And so they implemented a whole dose reduction program. They now have, I think, 11 of our systems, 11 or 12 of our systems, and they're utilizing them in interventional radiology, cardiology, and the OR. And they're seeing that not only are people much more attentive to where they're standing and what they're doing, but they're regularly kind of checking that screen in their periphery and seeing how they're doing on their radiation exposure. So it's really helped to make radiation top of mind rather than in the back of the mind to the back burner.
Okay, thank you. Next question. What is the current level of acceptable radiation exposure?
Very good question. So in the U.S., we allow a maximum of 50 millisieverts per year. There's another unit that you might be familiar with, which is REM, and that is 5 REM per year. That's the acceptable amount in the U.S. What's interesting to note is that in Europe, for example, and in most other parts of the world, the acceptable dose limit is 20 millisieverts per year, or 2 REM. So in the U.S., it's 5 REM, and Europe, it's 2 REM. That means we're actually 2.5 times more lenient in the U.S. when it comes to the amount of exposure that we allow. which is interesting because the effects, as I just have talked about this afternoon, don't change whether you live in the U.S. or in Europe. The effects of radiation are pretty much the same for most populations. So we do have a higher tolerance in the U.S., at least from a legal perspective, but that puts a lot more responsibility on us to be cognizant of how much radiation exposure we're putting ourselves in.
Okay, next one. How does the RaySafe i2 dosimeter communicate with the real-time display? Will the badge still work via Wi-Fi even in the middle of the operation? Isn't there a lot of interference?
All right, good question. No, so the real-time i2 radiation system has the little badge that you wear, the dosimeter, and it connects wirelessly with the display. We use an open band wireless frequency that connects the dosimeter to the display, and there really is not any interference. We now have literally hundreds of systems across the country and even almost double that across the world, and we've really not seen interference issues or concerns with other wireless devices. We've chosen a wireless range that's unique for our system, and will avoid any of those kind of interference types of issues. So it works quite well. And the other benefit is that it really is in real time. So if you're standing in a spot and you move the shielding, you'll immediately see that colored bar, which might have been in red, drop down to the green or to nothing. And that immediate feedback is what really helps you kind of reinforce that your behavior is correct.
Okay, fantastic. Here's one for you. Could you please speak more to exposure in relation to pregnant staff, the risks, additional measures they should take for protection?
Sure. So I think the important part is really kind of going back to Olara, and that is really keeping the doses as low as possible. And so for any pregnant staff, it's important that you talk with your department managers as well as include radiation safety into those discussions. Typically they'll sit down and put a program together that can help minimize your exposure, whether it be the number of cases, the amount of time in the lab, and those are really the things that they will do. And each hospital, and for that matter each state, have different requirements around pregnancy, so it's important to meet with radiation safety as early in that process as you can, because as different states have different regulations, oftentimes different hospitals will also have their own guidelines. I mean, the risks are, of course, that for a child in development, they really need to minimize the amount of exposure that can go into that pregnant staff member. So I think really the big takeaway is that the risks could be high if they're not managed appropriately by the hospital.
Okay, here's one. What is LAO?
Okay. So I think on one of the slides I had LAO as one of the acronyms. That is a projection or a particular angle that's used oftentimes in interventional cardiology. And that is a pretty common image angle that's used for typically for PCIs as well as other heart-related procedures. And there's two that are used, LAO and RAO. So that's what that references.
Okay, the next question is, we have shields in our OR. Will the RaySafe i2 work behind the shields, and do I even need it if we have the shields?
Good question. So if you have I'm guessing that the question relates to kind of a mobile, like a rolling shield that might be put in. I think I've shown a picture of one of those earlier. The intention of the RaySafe i2 dosimeter is that if that dosimeter is exposed to radiation, it's going to show something on the screen. If you have the ability to sit or stand behind a mobile shield, then hopefully you're not going to be getting any radiation. And so the system will still work. You'll still see your name up on the screen, but hopefully you won't see any red, yellow, or green next to your name because that shows that you're actually not getting any exposure. So the key there is, of course, it will work. It's just a matter of hopefully that shield will be preventing any scatter radiation from affecting you while you're behind it.
All right. Next question is, can reports be downloaded from the RaySafe i2 system and used to report staff exposure levels to regulatory authorities?
Right. So I mentioned briefly that there's a software that works with the RaySafe i2. It's called Dose Manager. And what that software allows you to do, whether it's at the administrator level or at the radiation safety level, is to really get a dashboard of all the users who may be using RaySafe i2. And from there, they can not only archive all the dose information, but they're actually going to be able to keep reports, and whether those be weekly reports or monthly reports, they can actually build the reports so that they're sent out every week or every month to each of the staff members. And then they can also do some data analysis to see who had the highest. I'll give you a good story that one of our customers shared with us. There's kind of a mid-sized, smaller hospital outside of Boston. And what they actually did is that after implementing the RaySafe i2 system, they created kind of a weekly challenge for all of their staff. So they created 3 groups: physicians, technologists, and nurses. And they actually, every week, at the end of the week, they would put in their break room a little sheet that listed the amount of radiation exposure for all 3 of those groups. So everyone was listed, and it showed who had the most and who had the least exposure for that week. And they created a little challenge that said, at the end of the month, whoever in each of those groups had the lowest amount of exposure, they wouldn't have to take an on-call shift. So they kind of created a little bit of internal rivalry to really maintain low exposure, present the best practices that they could to keep themselves as safe as possible. So it's a really nice thing that we actually now share as a best practice. It's whether they decide to add in the shift off or not is up to them and that competitive side of it. But being able to share lowest doses on a weekly or monthly basis is something that keeps everyone comparative to their peers.
Okay, one just came in. It says, how would this help with the orthopedic issues? Staff would still have to wear lead protection.
And I'm guessing by this, they might mean the RaySafe i2. Does that sound right?
I believe so.
Okay. Yeah, realistically, this is not going to directly impact the orthopedic issue. A lot of the other things we talked about are what you need to be attentive to with the orthopedic side, which is really trying to minimize the time in the lab when possible. Once you're done with the case, you can absolutely take, and you're out of the lab, you can take the lead off. But I think just like in any sort of work environment, being attentive to your ergonomics and what you're doing so that the joint issues, the hip issues can be something that you try to minimize the pain toward. But the RaySafe i2 probably is not going to be the right, really going to impact the orthopedic issues. There's probably other things that should be focused on for that.
Okay, next one. How do we use the RaySafe i2 to manage dose for the staff as a whole? Is there reporting in the software?
Yeah, I think I started touching on it. I can probably go a little bit further. Is the Dose Manager software is really like a dashboard that, and here's an example of how it's sort of used, is every one of the staff members show up in that software. And so, for example, we had a radiation safety officer that used to work with us, and it was very close to me, his office was, and so we would get together and kind of talk about some of the challenges that radiation safety or department directors have. And he shared that in any given month at a large facility that he used to work at, he had about 300 radiation workers in his, that he oversaw. And he said in any given month he would spend from a couple of hours all the way up to 10 plus hours simply chasing down people who were over their dose limits on a monthly basis. So if you think about what that means, you could have 3 people, 10% maybe, 30 people, 3 people that he would have to chase down. And he explained that anytime a radiation safety officer has to work with and identify the causes for high dose or overdose reporting, you have to speak with them and interview them. You have to often observe their practices and then provide additional radiation safety training. And so the amount of time that goes into that, both for for the radiation safety team as well as for the clinical staff can be a lot of time taken away from their primary responsibilities. So what the RaySafe i2 system and the dose manager can do is actually pinpoint different periods so they can zoom in the software on days of the week or months of the week, weeks of the month, where there's high doses that were involved. And then they can actually pinpoint either repetitive practices, perhaps some trends that are leading to some of those high doses. And then they can realize how better to improve that. So if they see, for example, as I gave the example earlier, that Nurse Susie was oftentimes stepping up to the patient, and they can observe that practice, and then they can verify it in the dose manager software, that's going to allow them to educate or re-educate Nurse Susie on how she can improve her practices so that she can avoid doing that. And those are going to help keep her exposure levels lower.
Okay, next one. What is the turnaround time for service and calibration on the i2?
Sure. So the nice thing is that once you've implemented the RaySafe i2, and once it gets ordered, once it gets implemented, it usually takes about 3 weeks to a month after an order to have it installed. We provide both the applications training and the in-servicing. And then the very nice feature is that there's actually no annual calibration, there's no annual service or anything required for it. So the will work pretty seamlessly once it's been implemented and once you've been provided with that in-servicing.
All right, got a few more here. How do I manually transfer data from the badge to my PC?
Sorry, could you repeat that one more time, John?
Yep. How do I manually transfer data from the badge to my PC?
Gotcha. Yeah, so there's a couple of ways that you can do that. One is manual, as you asked, which is a little cradle device that's included that allows the dosimeter to interface with our software on the computer, and it works just like a little USB cradle that you connect it on, interface it with the software, and then you can choose to download the dose data into the software. The other method is actually a little more automated, in which the real-time display is networked to the system in your hospital. And within the software, if the real-time display has been networked, you just click a button that says sync, and it'll automatically pull in the dose data from one display or from multiple displays. And so you can actually pull in dose data from 3, 4, 5 labs, whatever you have, or if it's hospital-wide in multiple departments, can be pulled in all together and then viewed by whoever is managing dose, whether that be a radiation safety committee or team or the department director or lab manager. And then they can actually compare all the dose information for the multiple users.
Okay, we got time for one more question. Last one, will the RaySafe i2 badge work underneath my scrubs?
Good question. So the RaySafe i2 dosimeter is worn outside the lead vest, typically on the front in the torso region. But absolutely, it can be worn underneath, whether you're wearing scrubs or a bunny suit or an overcoat or what have you. You can wear it underneath that. The key is to wear it on the outside of the lead vest, which is a little bit different than what you might do with your legal dosimetry. Depending on the dosimetry setup you have, you might have one legal dosimeter that you wear underneath the lead. Sometimes you'll have two where you're one at the thyroid and then one underneath. With the RaySafe i2 dosimeter, you're going to wear that on the outside, and it's just going to measure the scatter as it comes in and hits you. So the objective there is to really give you a real-time reading of scatter outside the body. But yes, to answer the question, it will work underneath scrubs or a bunny suit or any clothing that's worn outside.
Okay, fantastic questions, everyone. Thank you so much for submitting those. That's going to conclude today's webinar. Thank you, Tyndon, and thank you again for today's sponsors, Fluke Biomedical. One lucky attendee will win lunch for their entire department. Details are included in the post-webinar survey, which will appear on your screen shortly. You must complete the survey to obtain your certificate. If you do not see the survey, then email us at webinar@mdpublishing.com. Thanks again for a fantastic OR Today webinar. Have a great rest of the day. We'll see you next time.